Our next speaker is Dr. Patrick Kiely, consultant rheumatologist at St George's Hospital, London. Patrick is one of our medical advisors and has a keen interest in the links between GH and joint disease, to the extent that he instigated and runs an arthropathy clinic for people with GH at St George's. His survey of our members a couple of years ago revealed some very interesting diagnostic markers for GH, and he's taken this work forward to be one of the founders of a European working group called HARI, or the Haemochromatosis Arthropathy Research Initiative. So today Patrick is going to talk about genetic hemochromatosis and joint disease.
Right, thank you, Howard, and thank you, David, and it's a pleasure to be here, and thank you all for making the effort to come on a Saturday. So I'm Patrick Kiely, and I'm a rheumatologist. I work in St George's in Tooting, and my journey with this condition didn't start that long ago, back in 2011. As you know, certainly in London, if you want a bus, you may wait half a day, then two turn up at once. And I waited 12 years through my career, and I saw 2 cases of hemochromatosis within about 2 or 3 months. And just like these 2 buses, which are both the 159 to Streatham, the cases were different, but they were both hemochromatosis. So if you look at the literature, and this is literature which was generated by the Society nearly 10 years ago, you find that arthritis and joint pain stands out as the most frequent symptom that patients complain of. And therefore, one might argue that therefore it really is the bread and butter of the rheumatologist, because that's what we do. We look after patients with joint disease. And therefore, I assume there must be an awful lot of literature on this type of arthritis, because clearly for you, it's extremely important manifestation. But in fact, if you look at the literature, there was very little literature on hemochromatosis arthritis. And what there was would lead to the general conclusion that if you have iron overload at diagnosis, the worse the iron overload, the more likely you are to have arthritis, and maybe the worse the arthritis is. And there's this threshold of 1,000, which is broadly sort of quoted across the literature as being a sort of threshold you'd wish to be below when you're first diagnosed and before you start venesection. But in fact, it's further scrutiny, this sort of conclusion comes from fairly small series from Australia, 41 patients, and then a larger series from the French Haemochromatosis Association, who sent out a questionnaire to their patients. So I thought, well, this is all very interesting, but there really ought to be more data on this. And so I decided to set up a clinic, very much supported by the Society and promoted by the Society, and to whom I'm very grateful for letting people know that I was going to do a clinic. So the clinic was started at the end of 2012. It runs on a Monday afternoon, alternate week clinic, giving people a chance to get to London, which is usually the easy bit, and then the difficult bit is getting down the Northern Line from central London down to Tooting, which in itself is a slow journey. But nonetheless, I've seen about 85 patients so far, 78 at the end of 2016, and some, of course, came from my locality, but some promoted by the Society have come from much further afield. And if you're a patient here who's seen me, I'm very grateful to you for coming and making the effort, because the more patients that I see, the more I learn and I discover and think more clearly about the condition. And what I found was that the 2 sort of headline things that patients almost universally said to me were, number 1, why did it take so long to be diagnosed? I had all these aches and pains for several years maybe before the penny dropped. And number 2, now I've been diagnosed and I've been venesected, I'm still in pain. And what do I do about the pain? And of course, pain is incredibly important because that limits and reduces quality of life. So I'm going to talk now, in the time I've got, about the diagnostic side of things and how a recognition of the arthritis and a particular type of arthritis might aid earlier diagnosis. Treatment and managing pain is another lecture completely, but in your packs you will have a 4-sided leaflet called Treating Arthritis, which we've very recently written. In fact, it just was published in March, it was last month, this is the 1st of April today. And so I hope you'll find that useful and interesting to read. On top of my clinical experience, where I saw patients myself, again, with the Society's help, we wrote and developed a survey which was sent out in 2014. And if you responded to that survey, thank you very much for doing so, because that survey produced a large number of responses, from all sectors of the UK, some from Ireland, some from Europe, some from America and Australia, where we asked a range of questions, asking you about how you were diagnosed, what was wrong with you, and then focusing on the joints. So I'm going to show you some of the results of that survey, but the emphasis of this is very much on how could we pick this up and get it diagnosed quicker. So we've got 2 groups of patients, 62 in this particular subset, who I've seen myself in the clinic. That's some of you who have come to see me in the clinic. and then the 470 of you who very kindly answered the survey. Very different populations. These patients clearly had arthritis, or they wouldn't have bothered coming to an arthritis clinic. Probably had quite bad arthritis to make it worth their while to come to London to an arthritis clinic. So that's one end of the severity spectrum. And these here are patients who have the condition and may or may not have arthritis. And these patients have not been examined by rheumatologists. This is just what they have said about themselves and how they see themselves. And as you can see, most where the diagnosis was known were C282Y homozygote. But I was quite surprised that quite a few of you had no idea what your genotype was. And I would encourage you to think a bit more about your case, get more involved, and find out basic facts about your disease. It'd be nice to think you did know what your genotype was, because that has genetic consequences to your family. The mean age of diagnosis in the early 50s, absolutely typical. And the mean time since diagnosis when I saw the patients or when they answered the survey was about 6 to 9 years later. So you can get diagnosed because someone in your family has already been diagnosed and therefore you're invited for screening. You can be diagnosed because you've been involved in some sort of random screen, a well-man check, a well-woman check, a Bupa medical, that sort of thing, and a company medical where you just go and give an armful of blood and people measure things on you out of interest. Or you get diagnosed because of symptoms. And this is more than half of you. And therefore symptoms are really important to try and find a group of symptoms which trigger the thought, could it be the iron? And that, of course, is a problem because the symptoms that are generally expressed by patients are not sufficiently characteristic for the GP to think iron. So the point of my talk now is to try and think a bit more about the joints and ask the question, is there something in the joints which might actually help us get the diagnosis a bit quicker? And of course, in group 1, everybody had joint symptoms because they wouldn't have come to an arthritis clinic without joint symptoms. But in the survey of those who responded to the survey, 85% admitted to joint symptoms, of whom 3/4 had had those joint symptoms before diagnosis. So therefore, could those joint symptoms have been a clue to make the diagnosis a bit quicker? This just rams home the point that nearly half had had joint symptoms for more than 5 years before the diagnosis was made. And it's joint symptoms, joint pain and fatigue, which stand out head and shoulders as the two most common symptoms patients in group 2 said were the earliest symptoms related to their haemochromatosis. And all the other symptoms, whether it's abdominal pain, menstrual problems, sexual function, diabetes, dizziness, liver problems, chest pain, loss of body hair, mood swings, blah, 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 they're all very non-specific. That sort of thing is a story given to GPs day in, day out. And there's nothing specific about that to really help the GP think, oh, maybe it's the iron. And joint pain, well, fatigue, again, is an extremely common symptom, but joint pain, maybe if we could recognize something in the joints that was different, could get the diagnosis a bit quicker. Because it's the GP, 38% of patients were diagnosed by the GP, just under 1/4 by the haematologist, and about 1/5 by a gastroenterologist. And very few are diagnosed by the rheumatologist. Of course, for us, it would be quite easy because we might recognize the joints as being unusual. But it's what can we do for the GPs so they can recognize the joint problems as being unusual. And it's pattern recognition, which is how doctors work. 80% of the diagnosis comes on the story you give the doctor. And in that story, we are looking for a pattern. We're trying to work out what you're saying. Does that fit into some neat diagnostic box? So what on earth is this? It could be something on a barbecue. Who knows what it is? Hard to say. But when you get a few more details about the story and the penny drops, then it becomes clear exactly what it is. Okay, so what sort of arthritis is it? Well, the textbooks will say it looks like osteoarthritis, which is a degenerative cartilage thinning and degrading condition, with some extra calcium in the cartilage, which is these little bits of white on the X-ray, and the iron fist, which is where these joints here, the metacarpophalangeal joints, particularly number 2 and number 3, are preferentially affected. Now, for the GP, that would just look like osteoarthritis, which is very, very common. There's no need to do a ferritin for that. For the rheumatologist, we know that you rarely see osteoarthritis out of the blue in these joints here. You do see it in the PIP joints, you do see it in the end joints, what we call the DIP joints, but we rarely see osteoarthritis here. So for me, if someone came into my clinic with osteoarthritis as a reason for referral, and I saw it in these joints, then an alarm bell rings and I do the test, and that's straightforward for me because I'm the rheumatologist. But for the GP, that's just too that's too much to ask. GPs have to know an awful lot about everything. And they will know a certain amount about a lot of things. For the GP, they'll get its osteoarthritis, but rare will be the GP who would be able to tell who would recognize the fact that the MCP joints actually are a very uncommon joint to be involved in osteoarthritis. And whilst you might think, well, if only the GP had known that, I'd have been diagnosed, that's quite a lot to ask. Consider the workload of the GP. So then you go to the survey and you ask, okay, well, if you had joint symptoms at the time or before diagnosis, what was the first joint to be involved? So the MCP comes up, and then the ankle comes along as the next one along. Now, the ankle is a much more interesting joint to me because this has been shown by others to be affected fairly frequently in haemochromatosis, and yet in the world of osteoarthritis, we don't see much ankle osteoarthritis. So I'll show you a few pictures now, and then we'll come back to the ankle. So when you see the hands, when we talk about osteophytes, osteophytes are new bits of bone which come out of a joint, and that's characteristic of osteoarthritis. Common or garden osteoarthritis has new bone. That's the bony swelling, the knobbly knuckles that people talk about their grandparents having. In haemochromatosis, they are particularly exuberant, these osteophytes, and in the MCP joints, they come out like a little hook, and so they're called hook osteophytes. But as well as these joints being affected, you'll see there's disease here at the base of the thumb, there's disease here in these knuckles, and even disease here. So whilst we see the MCP joint as a characteristic joint, it doesn't mean that's the only joint in the hand which can be affected. All the other sites can also be affected. But what's different about haemochromatosis is that these MCPs are involved, where we won't see those involved in common or garden osteoarthritis walking into the surgery. And here's another example. I hope at the back you can see there's a florid, exuberant osteophyte hanging off the bone here. There's also a destroyed base of thumb, awful-looking PIP joints, and some disease at the DIPs as well. And indeed, when we looked at the survey, we found that whilst the MCP is a characteristic joint, patients in quite large numbers were reporting problems at the base of their thumb, in their wrist, and at the other side, so DIP, PIP, and MCP. And indeed, if you go to the literature, this is back to the Austrian and German study where they looked at, they compared osteoarthritis patients with haemochromatosis patients. These are the different joints, DIP, PIP, base of thumb, wrist, and MCP. These are the haemochromatosis patients. These are your common or garden osteoarthritis patients. This is the MCP joint, much more disease here than over here, and other differences as well. So for the rheumatologist, it's quite easy to tell the difference, but for the GP, it's a lot to ask. And here's a lovely example of how imaging can help us. This is the MCP joint with the hook osteophyte sticking out. This is a CT scan. This is a 3D reconstruction, rather like stripping all the tissues off the bones and seeing what your hand would look like if you were a skeleton. And you can see the extra bone coming off the edge of the joints, but also a lot of arthritis here as well, and in other places too. So the technology in medicine is incredible. You know, the stuff we can see, you've seen the Ferry scans, this sort of thing. The imaging of the human body has come on in leaps and bounds. It doesn't particularly help me in clinic, it doesn't particularly help you get diagnosed earlier, but it gives you an idea of where the imaging is. So now back to the ankle. So the ankle is often affected and sometimes the first joint to be affected. So why is that a big deal? So here is a series of patients coming to an orthopedic department with advanced osteoarthritis of knee, hip or ankle. And this is in 1 year, 639 patients. So a quarter had hip osteoarthritis, 2/3 had knee osteoarthritis, but they only saw ankle osteoarthritis in 7.5%. And furthermore, whereas hip and knee osteoarthritis, generally speaking, is primary, so it just comes out the blue, in ankle osteoarthritis, it's more likely to be post-traumatic. Now, haemochromatosis, ankle osteoarthritis is going to be primary. So you've got two red flags now. The fact it's in the ankle at all, and the cause has no obvious traumatic predisposition. So an orthopedic surgeon seeing osteoarthritis of the ankle walking in the door would expect the person to have had a history of trauma. So sporting injury, twisting their ankle, fractured tibia, that sort of thing. So I've got a terrible ankle, oh, well, I've played a lot of rugby or football, lots of injuries, and you see, okay, fine, we don't often see ankle osteoarthritis, you've injured it in the past, that's what's happened. So if you see ankle osteoarthritis at all, red flag, and if there's no trauma, second red flag. And indeed, this particular group went on to wait 13 years to get another 639 patients, all with ankle osteoarthritis, and the difference was even more striking. So 7% were primary, no obvious cause, that's where the haemochromatosis patients would fit in, and 69% were post-traumatic. So that's why it's an interesting thing. And here's another study, again, showing that most ankle osteoarthritis is post-traumatic. A bit is secondary to other types of arthritis, such as rheumatoid, and in fact, even haemochromatosis is listed as one of the secondary causes in this paper. So the vast majority of GH patients have non-traumatic ankle pain, and that is, I think, an important thing to recognize. What do the ankles look like? So I've x-rayed many ankles, and thank you to those of you who have come to my clinic. And I started to notice there are a lot of cysts appearing on the x-rays, which I thought was a little bit interesting. And then, of course, we did MRI scans. On the MRI scan, the bone should look this sort of colour, sort of hazy, sort of grey colour. And here, either side of the joint, you see it's whiter than it should be. And if you're close enough to the screen, you'll notice this is actually lots of little cysts. And there's other pictures here. Oh, no, there's one more picture here. Well, that's it there, showing all these cysts either side of the joint. Yeah, there is another picture here. It's a bit easier to see here. You see almost like bunches of grapes sitting here either side of the joint. So what I didn't know until recently was what would an ankle look like in common or garden osteoarthritis? Is there something about the haemochromatosis ankle that could be distinguished from everyday osteoarthritis? So we set about trying to study that. So from the patients who came to my clinic, I had the MRI scans all ready to look at. Then we had to find controls, and they were really hard to find. It's really hard to find primary osteoarthritis of an ankle to compare with the haemochromatosis ankles. And in the end, we had to settle for second best, which is patients come into the hospital being seen in an orthopedic department with hindfoot pain, that's basically ankle region pain, of sufficient intensity to prompt an MRI scan being ordered. And so you'd understand in the orthopedic surgeon's mind, you come in with a bit of a problem. If it's minor, and we can deal with it. No need to do fancy tests. But if it's particular severity, they'll ask for an MRI scan. So I've been able to compare the MRI images of patients yourselves with haemochromatosis with patients with hindfoot pain requiring an MRI scan in a secondary care setting. So we basically, I won't bore you with the details, but you look at the images and you have to find some sort of scoring system to work out what are the features. And we looked at a number of features in different regions. So out of interest, you say, how can you tell whether one joint is better or worse than another joint? You have to define a region of interest. You draw a line, and anything going on below that or above that is one region of interest. Anything below there is a region of interest. Then here, this is the subtalar joint, and we have a region of interest here and a region of interest here. And so you define your region of interest, and then you count what you see. Cysts, cartilage thickness, osteophytes, things like that. You do a counting exercise, and you compare the counts in one group with the counts in the other group. And what we found was that for the ankle, with cysts being the most important outcome of interest, because that's what I was seeing on the x-rays, we found the scores for haemochromatosis were significantly higher than the controls, but not so for the subtalar joint. So here's some examples again. Here are the cysts either side of the joint. Here's cysts in a control patient. So you can see at first glance, this is much larger and more easy, and that's going to score higher. That's a score of 8. Here, this one scored 2. And that's the sort of comparison you do. And it's all done blinded. The reviewer of the x-rays got no idea which group the patients belong to, and therefore you have a proper analysis. Here's some more images. Again, bone marrow lesions and cysts on either side of the joint. This one scores 6, this one scores 4. And that's the way we do research, trying to score things in a blinded way. When we looked at the other results, so cartilage loss, the size or extent of cartilage loss, osteophytes as extra bone, they were all significantly higher in the ankle of the haemochromatosis patients than in the controls. And for some of them in the middle aspect of the subtalar joint, but not at all in the posterior facet of the subtalar joint. So we are seeing some differences, particularly in the ankles. And here's another example. This is osteophytes, which are harder to see on the MRI. And this is, again, images of cysts. And here's one here of cartilage thinning. So I won't bore you with the details, but it gives you an idea of how research is conducted. So the conclusion, therefore, is that in comparison to these matched controls with hindfoot pain requiring an MRI scan, the haemochromatosis patients had significantly higher scores at the ankle and the middle facet subtalar joint for cysts, for extensive cartilage loss, and for osteophytes. And therefore, for the radiologist who's reporting that MRI scan, if they see that, they could then potentially say in their report, have you considered haemochromatosis? Suggest check serum ferritin and transferrin saturation. 2 really cheap tests to do. And radiologists will do this. When a radiologist reports your chest X-ray, your liver ultrasound scan, whatever, if they see something which wasn't expected by the referring doctor, they will say what they see, and they'll suggest what you should do about it. And that's how we work in partnership with radiology, because they report what they see, and they raise, they raise suggestions what to do about the result. So, summary. Oh, I'm on orange, right. So, patients that I saw in my clinic, all of you lot who very kindly responded to the questionnaire, thank you again for doing so. You generally get diagnosed in your 6th decade. Fatigue and joint pain are the head and shoulders most common symptoms, often are present for 4 to 5 years before the penny eventually drops, often with a ferritin of over 1,000 by the time the penny drops. And over 50% of you relying upon pattern recognition by the doctor to think iron, and that is the challenge. So number 1 issue, diagnostic delay. The symptoms are very prevalent. They predate the diagnosis in 3/4 of the cases by more than a year. And of the commonest joints that we see involved, for me, the MCP joint and the ankle stand out as being the atypical sites. It's a lot to ask a GP to recognise the MCP joints in a hand, but I don't think quite as big a task to advise the GP to recognise the ankle, because the ankle is a big bit of the body. And so pattern recognition is absolutely crucial, and we're now embarking upon effectively an educational campaign with GPs to think ankle, osteoarthritis of the ankle, without any trauma, perhaps measure the iron. And if you get as far as an MRI scan in an orthopaedic clinic where no one's thought about iron, if the radiologist sees these features, then they too can contribute to diagnostic delay and shorten it by suggesting to the referring orthopaedic surgeon they might like to measure ferritin and transferrin saturation. So the phenotype is early age of onset, lack of trauma, MCP and ankle being the discriminatory joints, and if you get as far as imaging, seeing these features, could it be haemochromatosis arthropathy? So a number of acknowledgements, particularly to the Society, Kit and Janet, who helped with the questionnaire development, Janet's daughter and CD, who helped with data collection and analysis, and without your involvement, we wouldn't have this sort of information. And within my department, my colleagues in radiology, the 3D CT image, that beautiful image of the hand, and the MRI hindfoot study from radiology colleagues. Since all this work was done, with Barbara's help in her role as president of EFAP, I've actually managed to collect together the very small number of rheumatologists in the world who have an interest and are involved with research into haemochromatosis arthritis. And this is Axel from Germany, Jochen from Austria, Barbara from Germany, Pascal from Rennes in France, Stephanie from Freiburg. This is a retired professor from Canada and another great rheumatologist in Fremantle in Australia, all of us convening to talk about what we can do for yourselves. And the first result of our efforts is the treatment article which you've got in your folder. And that's the treatment article which you've got. Now, just a final sort of thing just to lay down as a few thoughts for you on your way home, a few unanswered questions. So you've heard today that the sort of general message is that you have a genetic abnormality that leads to hepcidin deficiency and iron overload, and that leads to a whole heap of problems. And some of those problems include a characteristic arthritis. But there are some conundrums, and here they are. First of all, whilst getting rid of the iron helps an awful lot of this stuff, getting rid of the iron rarely helps the arthritis. And most of you said this in the answer to the questionnaire, and most of the patients I've spoken to who have met me face-to-face say that despite getting venisected, my joints didn't get better. Indeed, they've got worse. Secondly, having been de-ironed and been in the maintenance phase, new joints join in. So what are they doing joining in when there's no iron left in the body? So that's a conundrum. And then thirdly, we have patients who have either no measurable mutation or they have a mutation, but they've not yet got any demonstrable iron overload at all, having the arthritis. So the thought is starting to be placed in our minds that maybe aspects of the arthritis are iron independent. For sure, iron may be important, but there's these conundrums which make me wonder whether maybe there's something else about the genetic abnormality which does things to bone or to joints, which doesn't strictly need you to have tons of iron. So what drives pathogenesis, the medical term for how you get disease? How does the arthropathy in particular relate to iron? And perhaps do HFE mutations have other consequences that lead to an osteoarthritic process dominated by cysts and osteophytes, as well as the iron consequences which you all know all too well? And with that, I say thank you very much.